Welcome to this concise video log on HIV and Aging, the Golden Compass program. This program is provided by Clinical Care Options and is supported by independent educational grants from Gilead Sciences, Merck Sharp and Dome Corp, and Vive Healthcare. This vlog was recorded by Dr. Monica Gandhi. Before we begin, please note our disclosures on this slide. This vlog is part of a comprehensive educational program on caring for aging patients with HIV. You can gain CME, CE, or CPE credit for viewing these vlogs and download the slides by visiting our website, clinicaloptions.com.
Hi, I'm Dr. Monica Gandhi from the University of California in San Francisco, and I wanted to tell you about a case and tell you about a program. So I just saw an elderly patient living with HIV who represents a challenging type of case that I often encounter, and I'm going to share some details about the case and what we can learn from it, and how this kind of case helped us design a program here in San Francisco that we think helps serve the needs of people living with HIV who are older. So this was a 72-year-old man. He lives with HIV since 1988, and he has actually been on a stable regimen of bictegravir, tenofovir, alafenamide, and emtricitabine with good adherence over the last couple of years. He has some comorbidities. He has mild coronary artery disease, hypertension, and hyperlipidemia. And in terms of social history, he does live alone, and he has been particularly lonely during the COVID-19 pandemic. He has a very high CD4 count at this point of 828. His viral load's undetectable. He does have some resistance in the RT gene from the past, an M184V and a K103N, and his BMI at this point is about 27. He has a normal CBC, normal metabolic panel. He is not positive for hepatitis C. He is immune against hepatitis B. He is negative for HLA-B5701, and he does take an aspirin, a atenolol for his high blood pressure, and a statin for hyperlipidemia. So I think what this case highlights for us is that here is an older man who got diagnosed relatively early in the HIV pandemic. Though I didn't go into it in the case presentation, he lost a lot of friends, he lost a lot of partners, and he, at this point, is much older and living alone. There's a lot of social isolation here. He also has what's common in older people living with HIV, which is concomitant comorbidities of other conditions that can contribute to the risk of cardiovascular disease, coronary artery disease, and he also is someone who I think needs support in a special way. And so what I wanted to tell you a little bit about is the epidemiology of HIV here in San Francisco that led us, along with cases such as this patient, to formulate a new program at Ward 86 that we developed purely to respond to the needs of older people living with HIV. So you can see here is data on the left-hand side up to 2019 about the people who are living with HIV in the city of San Francisco, and also number of new diagnoses as represented on the bottom. And, you know, the number of cases, certainly because people are living longer, have gone up. Obviously, the cases of deaths have gone down, and having end-stage disease have gone down. And the majority of people in our city are still, who are newly diagnosed with HIV between 2010 and 2019, are in MSM categories, men who have sex with men. But you can see that in our city in San Francisco, it's the 30 to 39-year-old age group accounting for the greatest proportion of new HIV diagnoses. So it's not the very younger men in the city. And this is reflective of country-level data that the CDC estimates that in 2018, 17% of those who were newly diagnosed were in people who were 50 years old or older. So older populations need to be considered among those who are newly diagnosed, and they have special needs compared to older populations who've been living with HIV for a long time. So in 2015, here in the city, 59% of people living with HIV in San Francisco are over 50 years of age. This is slightly older than the general population of those living with HIV who are over 50 in the country, which is about 50%. And by 2019, because we do have a mature epidemic, we do have 69% of people living with HIV in San Francisco are over 50 years of age. And it really is this proportional shift to these even older individuals, those who are 60 to 69. And like my patient, about 8% of people living in 2019 in San Francisco are over 70 years of age. So what does the HIV/MA and primary care guidelines say for people who are older? Well, really, the life expectancy, as you know, at this point is really equivalent to those who are living with HIV and those who are not, if there is uninterrupted access to antiretroviral therapy. And so if we look across the planet, 50% of those living with HIV are over 50 years. But what's important is that we don't, across the planet, we certainly don't have uninterrupted access to antiretroviral therapy. And the other aspect about being older is the important aspect of managing comorbidities. Those who are older, those who have had long periods of time with HIV, have higher rates of inflammation, have higher rates of so-called accelerated aging, and they need comorbidity management to be aggressive. And we do need stigma-free, culturally appropriate, patient-centered treatment in each age group, including those who are older. And when we look to the primary care guidelines, remember that if we think about our patient here, we have to be very strict about managing for comorbidities and for comorbidity risk factors like hypertension, hyperlipidemia, diabetes, and glucose intolerance. Have to have a major focus on older patients on bone because of some of the effects of antiretrovirals and HIV itself on reducing bone density, and continuing attention to mental health, depression, and substance use. And again, because we know from the CDC 2018 statistics that 17% of new infections in this country are in those who are age 50 or over, it is particularly important to pay attention to comorbidities and all of these factors in our older patients living with HIV. So I really wanted to tell you today about a program that we launched in 2017 for people living with HIV at Ward 86. And Ward 86 is a clinic in San Francisco. It's based at San Francisco General Hospital. It is one of the oldest clinics in the country. It was formed in January 1983. And what we did was we enacted a multi-phase approach to trying to figure out the best way to approach a comprehensive care model for people who are older living with HIV. And so we had several stages actually to developing our program. We started with a community needs assessment. We also did a literature review to look into what has been done for older patients, were there care models that we could adapt. And then we also started a pilot program called the Silver Project from 2012 to 2014, got data from that pilot program. And then finally, our last bit of data that went into developing this program was performing focus groups with patient groups who are older and also provider groups, and asked, what do we need to put together that would be the most comprehensive care plan for those who are older living with HIV? So the city needs assessment has been repeated and has been done over time. It started in 2010. And we have some long-standing survival programs, long-term survivor programs here in the city that helped us develop some of these older programs. And we did some community forums with these long-term survivor community-based organizations. The reason this was so important is not because just of the demographics that I just told you about, but because of the frequency of geriatric syndromes that occurs younger in people living with HIV than it does in the general population. So what do I mean by geriatric conditions? Well, if you do comprehensive geriatric surveys, these conditions are things like frailty, hearing impairment, mobility. And if you look on the right-hand side, this is a survey that was published in 2015 in JADES from our group. And you can see that these frequency of these geriatric syndromes are so much higher among those living with HIV than the general population. Incontinence, falls, visual impairment, depression, cognitive impairment, difficulty with activities of daily living, and over 50% of people describing a pre-frailty condition. So this survey was done in people over 50 years old. So because of all these geriatric conditions that happen at 50, when they may occur in the general population at 60, it was important for us to put together a program that also included a geriatrician, because some of these geriatric conditions are not as well managed by primary care physicians. Geriatricians really focus on frailty, safety in the home, falls. And so we had a geriatrician join our program as we developed our program. And this is important to say that if you look at 65-year-olds in the general population, that's usually the age at which they have this number of geriatric syndromes. So you can essentially say that people living with HIV have about a 10 to 15 year jump than the general population on some of these geriatric syndromes. And the other thing I wanted to point out in this data from this Jade's paper is there were certain factors in people living with HIV that were associated with a greater number of geriatric syndromes. And those factors were having a lower CD4 cell count nadir, so having more advanced disease in the past, a greater number of comorbidities, so having more of those being associated with more geriatric syndrome, and then being of non-white race, which could be a proxy for less access to care in our country. So really, all of these factors are the ones that lead you to even more need for a designated program. And so that's why it's so important to think about moving our age group down when we think about who do we want to serve with specialized programs, not 60-year-olds, not 70-year-olds, but 50 and up. And so that was an incredibly important part of how we designed our program. Is we started our program at age 50 and up. Then the second thing we did was focus groups. So the focus groups was really asking people, just getting together, patients in a room, and we had an over 50 group, 50 to 60, we had an over 60 group, and we even had an older group. And we said, okay, what is important to you? What are the things that you need help with that we're not addressing in our routine primary care here at Ward 86? And we also piloted a program called the Silver Project. And then after that said, okay, what was important to you about that program? And what people said, at least if you look at the patients on the left-hand side, is that addressing depression was the most important factor that needed to be included in these programs. The losses that people have experienced over a lifetime, especially long-term survivors, had led to high rates of depression and anxiety in this group. And that was the most important thing to address. Falls were important to address. HIV medication adherence was important. Social support. Memory, anxiety, and functional status were the others that were considered very important to address, and just how fast they could walk, gait speed. And then if you look over on the right, this was asking providers, and the same factors came up, even though providers were more concerned about functional status and falls at a little bit higher levels. So some of the same things, addressing social connections, addressing mental health, addressing frailty, addressing how to get stronger, addressing safety in the home, all these were considered important. And what else came out of our focus groups besides these specific components of programs? Well, that's the great part about qualitative work, is that you can get a lot of themes that emerge from these focus groups. And what people said is that I don't think my provider necessarily has all the knowledge that it takes to help deeply care for me as an older individual. So they wanted to know more about how can you include geriatrics in their care. There was an absolute need for social gatherings and social support where people could get together who were long-term survivors, or even newly diagnosed people with HIV who were older, so they could benefit from the experience of people who had HIV longer. And then what really came up that we had not assessed before is that it's hard to get access to these basic services, which are hearing, vision, and dental. And that came out as a huge component of, how do I get to my audiology? I'm losing my hearing. How do I get there? How do you navigate me to dental? How do you navigate to vision services? And putting that all together, all of these assessments, all of these surveys, and the focus group data, the Golden Compass program was born. And really, I want to tell you about the 4 components of the Golden Compass program, and you'll be able to hear that a lot of these themes emerged. So we focused on golden because that came out of the focus groups. People didn't like silver, they liked golden. They felt it was much warmer as you approach the older ages. And the compass came out of the desire to be navigated places, to know where to go. And so we came up with the Golden Compass as the name, and we have 4 points of the compass. The north point is heart and mind. And what we mean by that is that there's so much emphasis on cognitive decline and also this need for managing comorbidities that we started in the northern point having a cardiologist on site, a Ward 86, an HIV cardiologist who comes to our clinic to help with heart health. We also started brain health classes. So these are actually memory classes that people gather and meet and get kind of these tricks and puzzles and other things to help improve your memory. And we also started a program for cognitive evaluation and referral for neurocognitive evaluations and resources. The eastern point of this program is focusing on those geriatric conditions. So fall and balance evaluations, all this polypharmacy that can occur in older patients, again, focusing on frailty. So exercise classes. We actually started a program with chair exercise classes for people who weren't strong enough to be getting up, moving more. Also for bone health, we applied for funding and got a DEXA machine on site. And then we employed a geriatrician. So Dr. Green is this eastern point, which is really about bones and strength. Then the southern point was all to address the social conditions, this loneliness and needing a community. And so this would be social support groups, advanced care planning, what to do with your DPOA, social work services, and partnering with community agencies that have social groups. And then the western point was really to navigate to those simple services that are so important when you're older, but they're actually quite hard to access. And that was dental, hearing, and vision. And it was really ensuring that we have all the resources in place to figure out how people to navigate, including getting actually an audiology assessment machine on site. And then we implemented it, and it was started in January of 2017. And then we did a 1-year evaluation, and this was just published a little while ago. And this was looking at the first group, the first 200 people that were enrolled in the Golden Compass program. And I wanted to tell you how it went, essentially, so and what people felt about it. So of those first 200 people, the average age was 62 years old. And we did have a majority of men, which actually reflects MSM in our clinic. And most people were actually undetectable, but they needed all of these other things in terms of virologic expression. So we started the Friday afternoon geriatrics HIV clinic for screenings. We did vision screening, hearing screening there, and navigated people to dental. And we also had a clinical pharmacist consult there for polypharmacy. And again, the geriatrics was there. And these were some of our results in terms of patient satisfaction with acceptability of the components. I will tell you that people really liked the geriatrics component. They liked the geriatrics clinic. It was usually a one-time appointment with the geriatrician. 77% were very satisfied, and 97% were satisfied overall. And what that meant was that they liked this designated geriatrics visit that would adjust things in their medications and in their homes and in their strength that would last them for a while. 100% of people were very happy with the cardiology clinic on site. 88% were very satisfied. And liked this idea that there would be one-stop shopping and that cardiology would be on site. And then 93% were satisfied, with 80% being very satisfied with the brain health classes, and also with the wellness classes, 100% satisfied, with 76% being very satisfied with the wellness classes, which were those exercise classes. So a lot of high satisfaction with the components of the Golden Compass program. And we now will be looking out. We have enrolled more than 200, and we will be looking out over time to try to make this a sustainable model. We are getting, as primary care providers, more geriatrics training so we can extend the geriatrics assessments. So it's not just one geriatrician in our clinic doing all those assessments. And we have found really great outcomes, at least in terms of satisfaction. Now we'll be looking forward in terms of bone health and actual hard outcomes like cardiovascular disease, hypertension control, and hyperlipidemia. So to go back to my 73-year-old patient, you could see that he really had risk factors for cardiovascular disease and had known cardiovascular disease. So we referred him to the Golden Compass program, and he benefited from multiple aspects of it. He was referred to the on-site cardiology clinic where his hyperlipidemia and hypertension and medical conditions were optimized for cardiovascular health. We referred him to the geriatrician who looked at his medication list with the pharmacist, and assessed anything we needed to cut down. And also he was assessed for home safety in terms of outfitting his bathroom and ensuring that he was completely safe. Then we referred him to the brain health classes because he was worried about cognitive decline. And in the context of the brain health classes, not only did he meet friends, but he also had one session on advanced care planning for what to do with will and estate. And then finally, we had him go to all the audiology, dental, and vision of the western side of the campus, and we had him go to the social support groups of the southern side of the campus where he met new people. So he benefited holistically from the Golden Compass, and it was a wonderful thing for my patient. So it was really my honor to tell you about the Golden Compass program. It's something that we're particularly proud of here, and any component that you would want to adapt for your own clinical setting that you find speaks to your patient population would be great. And please feel free to contact with us. And anytime Dr. Meredith Green is the geriatrician in our clinic, or myself to talk about how to set up Golden Compass. Thank you very much for your attention.